the holiday season. Thank you so much for lecturing, taking the time to lecture today, Bahar.
Of course.
Okay,
Thanks.
bye.
Okay, fun times. Let me share my screen. And by the time that I share my screen, my topic is benign kidney lesions. Put a couple of things that you expect to see in my lecture today in the chat box. Put it to see. Mostly I do it because I want to see if any pathology I'm missing, I could add it on the next version. So hopefully I'm not breaking your heart. Okay. You see my screen?
Yes.
Yes, we do.
Great. So let's look at the chat box. AML, TSCC. Ashkan, I don't know what to do with those. So we keep it as it is, too small to characterize. They're too small to characterize. We cannot do anything. Proteinaceous cysts in general. Yeah, there are a lot of voters for cyst, oncocytoma. Great. So let's see how much we could cover. It's a little bit on the lengthier side. And so let's see, but like most of the lectures that we do together, I would like you to have a framework. It's not necessarily that, oh, how many pathology you see necessarily today. We could always do part of it later. But I like to have a framework of thinking. So today we talk about a little bit of anatomy, not much detailed anatomy that you need to know. I think most of you know it. We talk about infectious, inflammatory, calcific disease. I talk about a little bit of miscellaneous conditions. I couldn't find any good category to put them in. And then towards the end, I talk about the cystic masses and solid masses. So usually how it was done before, Antonio was doing the malignant kidney disease and he was mostly focusing on the cysts and solid lesions and then RCC and everything. But this year, I think it was a little bit of issue. He couldn't do his lecture last time. So I tried to do a little bit more on this, but as I said, I don't know how much time we have for this part, but I could guarantee that I talk about the most requested topics in the chat. So I'm just checking the chat box one more time before we start scarring. I don't know if I have a topic at talking about scarring, but I could see your point. Sometimes the scarring could be a little bit weird, and particularly in cases that you don't have any prior. So scarring could happen if there is any prior infection or let's say trauma or infarction, and then scarring could happen also after any procedure, right? So the patient had, let's say, vein resection, and then now you see a weird scarring and sometimes some changes in the perinephric fat. And the last one, medullary nephrocalcinosis. Okay, so hopefully we cover most. Talking about the anatomy. So again, not much to say. So cortex, we have a capsule obviously here. This is when you're on harbor view. You talk about the subcapsular hematoma, cortex, medulla, and then pyramids, right? Mainly in the medulla. I put this sonographic image here. I'm sure for those of you who have done ultrasound before, at least one time you have seen this weird thing that you're like, is it a mass? Is it not a mass? And something that we call column of, as you see here, the cortex separating the medulla come here. For whatever reason, it's normal. Sometimes it's hypertrophy. And then when there is hypertrophy, it looks like a mass. So it's basically a pseudomass pitfall. How could you make sure? In most of the cases, our texts are really good. They give you cine, and kind of when you look at the images, you scroll through it, they tell you, oh, it's a column of Bertina. And if you want to make sure, you could look at the CNA. Sometimes it's still confusing. Literature says that you could do contrast enhanced ultrasound for that. So if you give ultrasound at the bedside, you see the same enhancement at the adjacent parenchyma. Going a little bit microscopic, what you need to know about this. So we talk about the papillary necrosis and the importance of papilla when we talk about papillary necrosis. But as you see, the collecting system comes all the way. So basically the papillas are convergence of the collecting system. As you start here, you see the Bowman capsule here, you see the proximal and distal tubule all the way to the papilla. Moving on to the infectious inflammatory conditions. Okay, I want to brave PGY2 to describe this finding. It's nothing tricky. I could show you the finding too.
There are areas of hypoattenuating or hypo-enhancing wedge-shaped lesion in the kidney.
Excellent.
What else could we say?
Very good. So what do you think it is?
That could be that could be pyelonephritis. And there's fat shrinking.
Excellent.
Local
Yeah,
fat shrinking. Okay.
Thank you. Okay, so on the first image, we have axial contrast enhanced CT. As you see, perfect description. So subcapsular wedge-shaped hypo-enhancement. If you go to the literature and always talking about pyelonephritis, they talk about, yeah, there is striated nephrogram. But the reality is that this is a very classic presentation. Most of the cases that you see in real life, you just see subtle hypoenhancement. Sometimes you need to look at your coronal, sometimes you need to window a little bit to see it better. But if you want to remember one thing, if you see cortical hypoenhancement in a right clinical setting, because sometimes the imaging finding has overlap with infarction, so it's hard to say it's infarct or pyelonephritis. But if the patient is younger, if the patient has any symptoms of urinary tract infection or white count, you kind of go with this. So in general, the focal finding is more common on imaging, as you see. So here I just wanted, maybe this is a little bit more diffuse, so kind of you could make it as a striated appearance on this. I wanted to show you, this is the ADC map of the DWI imaging. As it shows, it has restricted diffusion. So if you want to take one thing is that pyelonephritis, if you're reading a CT from ER, make sure you look at your kidneys on coronal and axial, window a little bit. Sometimes it's really subtle. On the more severe cases, you see perinephric stranding, not in all the cases. You could raise the question, and the reality is that, like what we said in pancreatitis, pyelonephritis is also a clinical diagnosis, honestly. And most of the time we do imaging to see if there is complication or not. So this is an ultrasound. If you
Bahar, can I ask a question about that? This is Matt Perez.
Should I go back?
Think, yeah, just on the last slide. Yeah, specifically that image left. I feel like when the question's raised of pyelonephritis, it's usually pyelonephritis versus like renal abscess. And when there's a focal finding like that, I feel like I've seen people usually say something along the lines of cannot exclude like developing abscess. Is that something you would include or just leave it?
Not in all. Yeah, that's a very good question. Thank you, Matt. Not in all the cases. So for example, in this case, obviously we cannot put the ROI, but subjectively it doesn't look that cystic or fluidy attenuation. I don't think that if we were putting ROI on this, we were getting something less than 20 Huntsville. The other thing is that if you think about abscess, so hopefully I see more cases and it makes sense more. When you talk about abscess, so you could start from phlegmon. You could argue, could it be phlegmonous changes? Yes, but it doesn't look like an abscess, because if you go to the category of the abscess, many of those needs drainage. So the kind of, it is a little bit different management, but if it is phlegmon, usually they just do IV antibiotic. So the short answer is that no, if I see this finding, I cannot exclude abscess for such a case. If I see a lot of inflammation, if I see a little bit less density, it means that lower attenuation than this, I may put it may be early phlegmonous abscess changes. And what could they do? They could do ultrasound. Ultrasound is much better. Ultrasound on a case that if you pay attention, this is a normal cortex. And if you pay attention, this is a little bit more echogenic, if I could sell it to you. And then one interesting part is that unlike most of the itis that we always think about, okay, there is inflammation, it should be more vascularity. If you look at the pyelonephritis cases on ultrasound, you have hypovascularity. So if you look at the same area, this area on the Doppler, so you see, you don't see this vascularity here. So it is hypovascular. Kind of math question was alluding to this case, so I kind of talk about this case myself. So this is a typical abscess. Obviously, I chose a bacterial abscess that looks really like an abscess. As you see, the attenuation of the center is very low. There is a rim of enhancement. The abscess, if you put it somewhere else, it's an abscess, so it doesn't. The look is not something different from other sites. As we said, it's important to do imaging in cases of pyelonephritis for the complications. These are the MRs. As you see, it's a multilocular and it's very extensive. If you look posteriorly, it's extending to the perinephric fat and also posteriorly to the posterior abdominal wall. Kind of here, it's where you have the transversalis fascia. If I didn't have the culture on this case, it is hard. If I just give you these two and ask you what it is, you could say, oh, could it be a multilocular cystic lesion? Could it be cystic RCC? Yes, it's hard. But I just wanted to show you a case that we knew it's an abscess. So remember, typical abscess looks like abscess anywhere else. It could be multilocular, and based on severity, it could be really extensive with the inflammation in the perinephric fat. Many of the abscesses need drainage. So it's a little bit less typical. So let me take you to. So again, for the abscesses, I showed you a bacterial abscess, but always think about even bacteria, they're more indolent type. For example, tuberculosis, nocardia, that which more happening in the immunocompromised population, they don't have typical appearance of the abscess, because thinking about it, to have a typical abscess, you have to have a lot of your immune system and T cells activity. So the less typical abscesses are the fungal abscesses and the bacterial abscesses who are very indolent activity. This is kind of what I say more of a phlegmon is. So again, if you want to think about it, how did the previous case look like compared to this one? Now, I'm showing also MR to show you. You see, it's not. It's very dirty. It's heterogeneous enhancement. And if you look at it under ultrasound, it's not that anechoic that you expect from a typical abscess. A typical abscess has more. You could see debris, you could see septation, but again, it's too solid to be a typical abscess. So I want to brave PGY. We don't have a PGY 5 here. PGY 4. Maybe take this one. I could show you the findings. It's a multi-system finding. Describe the finding here. Maybe here, here. This is T2. This is T1 post. Just description, even if you don't get the finding.
Yeah, sure, Bahar. This is Blaine. I can talk about it. Okay, so on screen left, we have a coronal T2 weighted image, as you said, and I'm seeing a circumscribed area of relative T2 hypointensity in the left kidney, kind of in the lower aspect of the kidney there. I don't necessarily see the corresponding region on the middle image. Maybe that's corresponding to the region in the left kidney that we're seeing, but on this, what looks like a fat saturated post-con axial image, the right kidney also has kind of a round region of relative hypoattenuation. the left kidney looks abnormal there. The cortex looks thin, and it looks like there's this heterogeneous enhancement kind of posterior.
Yeah, mostly I wanted to show the, as you described. So this is kind of on T2. It doesn't look like a cyst because it should be bright. So it's a little bit hypointense, and kind of when you look at if these are kind of the same pathology in bilateral kidneys, I know it's a little bit hard how I cut it, but they're not super enhancing too, and they don't look like hemorrhagic cysts. They're not T1 hyperintense. So it's not a typical cyst. It doesn't look like a typical abscess or pilot. They're a little bit more too bright. And then let's move on to this.
Okay. So on screen right, let's see, that's also an axial T2. It's like there's a lot of bright fluid there.
Very good.
The pancreas looks abnormal to me. It looks kind of, I guess, increased in size with decreased cleft, and it's pretty hypo-intense as well. I'm trying to remember. I know pancreas is pretty T1 bright, but on this T2 image might be a little hypo-intense.
Okay. Your descriptions are great. So very good. Thank you. So regarding this, I kind of could argue that, does it look like a sausage? Maybe, I don't know. Some of these names, I think, is just a little bit imagination. IgG4 disease, overall, it's not that common in clinical practice, probably more common on board. The problem is that they don't have a very typical imaging finding for renal disease. So it's not something that I say, oh, if you see this imaging finding, it's an antimony, then you could call it IgG4 disease. One thing that is helpful to know about IgG4 is that it's a multi-system autoimmune disease. So it's helpful if you have, for example, cholangiopathy, if you have something finding in the pancreas, if you have kidney findings, kind of put it together and see, okay, could I throw IgG4 disease in my differential? Because it's kind of easy for them. They need to check the IgG level. It's a blood test, but think about it. And then something to remember is that it could be diffuse, it could be patchy, it could be in the perinephric, it could be single lesion or multifocal. It is hard, but I put it here just to think about it. The pancreas finding, it's a little bit more typical than kidney finding. Something that they describe is a sausage shape appearance. As Wang was describing, you don't see any of the lobulation of the normal pancreas because the pancreas is very chubby, right? There's a lot of edema in it. And then if I could sell it to you, if you look at the contour of the pancreas, could I tell you there is a very thin T2 hypointense. It means T2 dark rim around the pancreas. So this is a typical pattern of the pancreatitis. They call it autoimmune pancreatitis. That is kind of seen in patients with IgG4 disease. What do they do for treatment is steroid. So this one, again, it's a little bit more interesting for the board takers. Whenever I'm putting, or in real life, you have a patient with findings in different systems, think about, okay, what are the kind of different multi-system disease that I know? Let's start from here. What do I see on this picture? So I see hypoenhancement, probably it's the interpolar region of the kidney. Maybe here it looks subcapsular, maybe it's more extensive in the right than left. Could I put infarction? Maybe, does it look like infection? Perhaps not. It's not super typical to be this extensive. Doesn't look like a diffuse one that is striated. It's not typically look at the focal pyelonephritis. So far I say it's just hypoenhancement that I see in the bilateral kidneys, maybe right greater than left. And this is an image from the late gadolinium enhancement of the heart. So there are certain diseases that we do protocols for them if I want to give out the diagnosis. So when you study for cardiac MR, oh, I'm sorry. I gave it up. When you study for cardiac MR, based on the pattern or how you see the late gadolinium enhancement, there are different differential diagnosis. So for example, on this case, we could go back. I could argue probably there's a little bit of mid-wall enhancement, probably a little bit of mid-epicardial enhancement. Sometimes there is a little bit of overlap, and then here you could go. So you will find this image in many board reviews, but the most important concept is that look if the patient has multi-system involvement, think a little bit broader. Sometimes some diseases are not super common, but you may catch it. Again, like the IgG4 disease that I was talking about, it's not that there are imaging findings that I could tell you there aren't many, but just think about it. What are the most imaging findings? So you don't see discrete renal lesion. It's not that I could call it a mass. Mostly you could see it a big area of hypoenhancement. I would call it like hypoenhancing confluent area. And again, there is overlap of imaging findings with lymphoma and IgG4 disease. What else I could tell you about? A lot of us, we have heard about sarcoidosis when we are looking at, let's say, lung imaging or liver and spleen, but just remember that it could involve any organ. There's a good radiographics paper. So I think it is called sarcoidosis from head to toe or something like this. So talking about different imaging findings. What is the treatment? They go for a steroid. So this is a little bit, I would say, less common condition, but I put it for the more junior residents for description. So again, if you compare it with the other cases that I showed, it doesn't look like a lesion, but when you look at the kidneys, it's just, when look at this, it's kind of I show you what is the buzzword, but it's kind of a soft tissue thinking around the contour of the kidney. And if you look at the anterior pararenal space, you see all these soft tissue abnormality. It's very infiltrative. It doesn't look like a renal lesion, but it is kind of around the kidneys. I'm showing the same pathology on the coronal image. As you see, it's not that it's coming from the cortex or medulla, or you could say, where is it coming? There is no claw sign, but it's just very dirty soft tissue. I'm showing the PET to show you there is not much activity associated with this soft tissue. Again, something that is more common on board than real life. The buzzword for this is hair kidney sign. For the board takers, they like at-home Chester for some of the neuroimaging too. It's one of those multi-system, just for so it's a non-Langerhans cell histiocytosis. It's not something that they play with the imaging finding. If they want to give you a rare disease in exam, they will give you a very common. So always this is a rule. If they're asking you something really zebra, they will give a common imaging finding. If they're asking something really like very common, they show it on a rare imaging finding on a rare modality. So again, look, this soft tissue area around the kidneys, could we put the diagnosis just by looking at it? Probably not. Something that I would put in my differential if I'm looking at such a case. I would think about probably lymphoma. I put it, if I didn't have this part, probably if I see this much soft tissue infiltrative in the retroperitoneum, I think about retroperitoneal fibrosis too. What do they do? A steroid, and in some cases they need to do chemotherapy. Okay, done with the infectious inflammatory disease. Let's move on to the calcific disease. So I'm not going to talk about the nephrolithiasis. Renal calculus, I think it is covered by the ERAD people. So for calcific disease, what do I like to think about when I see calcification or hyperdensity that look like calcification in kidney? I like to think about where is it located. So location is important. When we move on to the next ones for the cystic disease, what do I think of? I like to remember my Bosniak classification. When I see a solid mass, what do I think about? I like to think about, okay, if this mass is enhancing or not, and what is the morphology? I talk about the morphology a little bit. Okay, so maybe a PGY 3. So calcific disease, we said, okay, it's important to know where the calcification is located. So what do you think about this case? Even if you don't say the diagnosis, that's totally fine. And if you didn't have MR, don't worry about these two, just these two. What is the arrow sign showing?
It looks like there's like calcification in the medullary. It's
Very good. Excellent. So could you think of any pathology?
like medullary nephrocalcinosis.
Very good. You got it. Okay. So I think Charisma, it was you, right?
Yeah, it's me.
Okay. So looking at these, so let me show, sometimes it's hard when you look at the finding if you cannot remember how a normal kidney look like. Just let's look at a normal kidney. So normal kidney, we talked about cortex and medulla, and sometimes it's coming a little bit lower down, but the echogenicity and the fact that you have, it's in the center, right? You have the renal sinus. So now let's go back to the case that I was showing. If you see, all the medulla are very hyperechoic, echogenic, and I was trying to show the posterior acoustic shadowing. So kind of, we look at the same pathology on the coronal. As you see all these hyperdensities are located where your pyramid are sitting. You could argue, could it be nephrolithiasis too? Yes, they could get stone too. So it is hard sometimes to say, oh, which part is the underlying calcification versus nephrolithiasis, and they could get renal stone. But again, looking at the location of the calcification and looking at the pattern. So most of the calcification on T1 and T2, they are dark. And as you see, again, they're in the medulla. In physics, you will read about some of the calciums that because of the T1 shortening, they could be T1 hyperintense, but again, we are talking about the classic ones that are hypointense. It means they're dark on T1 and T2. So what do you need to know about medullary nephrocalcinosis? So what is medullary nephrocalcinosis? Why it looks so weird? So basically, they are dilated collecting ducts in the renal pyramid. So because they're dilated, they're kind of a spongy-like appearance when they look at the gross pathology. Okay. So this is a normal parenchyma versus you see these collecting ducts are all dilated. This is the reason that they look so weird. Going back, I think what you need to know, sometimes they could get medullary predominant cyst, because if you think about the renal cyst, the regular renal cyst that you get, they're very cortical, right? Like this one or this one. But if you look at these cases, they are too deep, right? This is the reason that they say medullary predominant cyst, because the cortical cysts, as you see normally, they're more on the outer layer of the kidney. On excretory phase, they're talking about the paintbrush appearance. So I don't know, you could look at this blue arrow and kind of use your imagination, but just remember something. I don't know how much is practical, but the practical thing is that you will see calcification that are projecting over the medulla. For board takers, I don't think that there is any other value in this part. So what are the conditions that you see medullary nephrocalcinosis? If I want to remember two, I would say hyperparamedullary spongy kidney are the most important one, but there are other ones that has been described. Cortical nephrocalcinosis, again, location. So this is calcification, but again, the difference from the prior case, as you see, it's like somebody took a pen and drew the outline of the kidneys. What are the most important thing in real life? I would say most of the cases are acute cortical necrosis. So for whatever reason, there is an acute kidney injury. But remember that transplant rejection, I've never seen a transplant case to have cortical nephrocalcinosis, but remember that they could have it. Chronic glomerulonephritis and oxalosis has been described to have cortical nephrocalcinosis. Again, going over this is part of the calcific disease, but this is also a disease that involves a little bit of inflammation. Talking about XGP, so if you look at this case, so you see there are really large calculus here. You could argue that this is probably Stackburn. And then these patients, they have these stones for a long time. They get hydronephrosis, and then it's the inflammatory process. It's a granulomatous process. Some of these cases, the inflammation gets really bad. It could just invade the adjacent not vasculature, I would say mostly in the fat, and also it could get to the abdominal wall. If you want to put the combination, so most of the time, these patients come with a chronic course that they had stones for a while. Most of the time, the kidney, which is involved, it is not functioning and is enlarged. They have a central calculus, the renal pelvis gets smaller, they have expansion of the calyces. And again, the main thing for these cases is that, look, they're big calculus, there is hydro, there is inflammation. Most of the time, the kidneys, which is more involved, is not functioning. They're talking about the Verpos. Okay, so done with the common calcific disease, there is a category that I put at miscellaneous here. I didn't know where to put it because it's not necessarily go to any of the categories that I was talking about. So it's important any of the CTs that you look in real life or on board, see what kind of examination it is. Even if you're looking at the PACS and the text says, I don't know, contrast enhanced ultrasound, contrast enhanced CT, or I don't know, arterial phase, but it's not necessarily correct. They do mistake in labeling, they do mistake in timing. So always look at it yourself. So this is a non-contrast CT, and if you compare the right and left kidney, you see these areas of contrast, and this patient didn't get contrast on this. And if you go back to the patient jacket, you will see, for example, the patient may have the contrast enhanced CT, I don't know, 48 hours or something prior. Talking about contrast enhanced nephropathy, it gets a little bit subjective. I know that you guys have been dealt with it a lot, probably the most when you protocol this study. But the reality is that, okay, how much it is important to be worried about contrast-induced nephropathy. This is a little bit personal touch of me. This is a radiology papers came a couple of years ago. They looked at a bunch of scans, and then at the end, the reality is that the problem with the cases that we protocol and they ask for the contrast-enhanced CT is that usually they have so many other morbidity. Let's say they have diabetes, they're on metformin, they are hypovolemic, there are other things going on with them at the same hospitalization. And then, yes, the GFR is low. The art is that figuring out, okay, if the low GFR happened in the last, I don't know, 24 or 48 hours, or if it is baseline. But the reality is that when they looked at this many scans, and then they were adjusting the presumed risk factors, you could look at a paper and see what was the exact risk factors. The incidence of contrast-induced nephropathy was not significantly different from contrast material independent AKI. Just as a nutshell, I could tell you, it depends. Always I talk to the team, what are you looking for? If what they're looking for example, if it is an outpatient, the patient had low GFR and they're looking for, I don't know, staging of melanoma or clear cell RCC, which are mostly hyper-enhancing metastases, I'm like, it's not urgent, so just do it later, or maybe the kidney function get better if it is something that recently happened. If it is an inpatient, it depends what are they looking for. Always tell them that the non-contrast CT may not give the information to them. And then just somewhere in the back of your mind, think about, okay, it's a multifactorial condition. So papillary necrosis, again, something. So obviously we don't do fluoro IVP or conventional IVP anymore. We do urogram or CT IVP. but it's an important pathology, not super common or not we can diagnose it that much, but it's important to know about it. It's a little bit easier if you know the pathophysiology. What are these weird appearances that we see? So if you think about the main renal artery, when it goes to the kidney, it comes and divided to, let's say, 4 or 5 segmental artery. And then this segmental artery goes to the interlobar artery. Interlobar forms the lobar, and then at the base of the pyramid, you have the arcuate artery, right? So here, arcuate, and here we started from the main renal artery. And then, as you see, comes the glomerular, and then eventually there is vasa recta. So here it comes to the papilla. If you compare here, kind of towards the base and towards the end, the tip that is papilla, that you see here, you have plenty of vasculature at the base, which they're all tapering, but they are coming towards the papilla. Kind of the papilla has marginal blood supply. This is the reason the papilla is very sensitive to ischemia. So kind of, if you want to think about papillary necrosis, think about any condition that causes hypoxia or ischemia to the papilla. So then if you think about it, you don't need honestly to memorize many of these conditions. So I would say for the purpose of board, sickle cell, NSAID use, and DM probably are most common causes. And all of these, they're kind of dealing with the problem with the microvasculature, right? And then when there is this chronic hypoxia, these patients get some sort of chronic tubulointerstitial nephropathy. And based on how they get the necrosis, they could have different imaging appearances. Probably golf ball and T is the most common one. This is the one that you see, it gets necrosis, so you see part of the contrast here. But you could have signet ring appearance, kind of a clubbing, as you see here. So again, here I wanted to show you, as you see, for example, this is something in the cortex, something we call more cyst. So this is the black arrowhead, but compare it to these cystic areas that we see more towards the medulla. This is a case of papillary necrosis. Again, this is something not very common, but I just wanted to show you. So if you have looked at some MR before, you could say these kidneys are really, really dark. They're as dark as, for example, if I show you these bowel loops that have air, air has susceptibility and it looked dark. These kidneys are as dark as air. Why they look so dark? So they have iron deposition. Again, it's not super common, but they could happen, for example, in PNH, sickle cell. Sometimes patients with prosthetic cardiac valves, they may have lysis and they have iron deposition in the cortex of the kidneys. I don't know how much it's helpful. Maybe for board takers, just take a look at this. With this, we're done with the part that I wanted to talk about, miscellaneous. Let's move on to the cystic masses. So you all heard about Dr. Bosniak. So Dr. Bosniak, actually, he passed away a few years ago. He was a retired radiologist at NYU, and he was working even, I think, in early 2000 something. But he came up with Bosniak classification. It was a really smart idea. And then he developed Bosniak classification on CT. So use of Bosniak for MRI finding is a very, very recent thing. So a paper came out in 2019 that they applied the terms for MRI. But when the very first basic Bosniak classification for cystic masses came, so Bosniak 1 are the simple cysts. What is simple cyst? Is a lesion when you put your ROI. If it was PAX, I was putting a ROI, and if you want to get an accurate ROI, it should be about 2/3 of your lesion. So if this is 1.5 centimeter, it doesn't make sense to put, I don't know, 1 pixel ROI on it. So you should cover most of the lesion. If you put a ROI on this lesion, you get attenuation, or the number that you get on your measurement, less than 20 Hounsfield unit, you could call it simple cyst. That's it. The problem is that most of the CTs that we get, they're contrast enhanced CT, and it's not a multi-phase. And then you put an ROI on this and you get, let's say, 45. The problem with that lesion is that it is hard on just one CT say, is it a proteinaceous cyst or is it a renal lesion that is enhancing, maybe hypo enhancing? That is a problem. This is a reason that whenever you have a lesion that you cannot say for sure if it is simple cyst, you don't have any comparison to make sure, let's say, if the patient had CT from 2 years ago and it was also contrast enhanced, but the lesion hasn't been changed, probably it's a proteinaceous cyst. You look at the patient jacket. If there's an ultrasound, maybe you could figure it out from ultrasound. But if there is nothing, I think the best option for the patient is that to do ultrasound. You don't need to jump to the multi-phase renal MRI. You could do ultrasound first. So many cases that with ultrasound we are able to figure it out, but in cases that are really suspicious on ultrasound we cannot figure it out, they could do multi-phase. So simple cysts we kind of figure it out. And then as we move to the Bosniak 4, it gets more complex. What does it mean from complex? It gets more stuff in it. So for example, if you have a thin septation, something that is not, it's like hair-like, you're not worried about it. So it's Bosniak 2 and we don't do anything about it. Bosniak 2F, I go to the classification, neuro classification, because it has all the terms with more detailed explanation and tell you, okay, when do you put something in the 2F versus 3, for example. So 2F is the one that needs follow-up. I would say probably every 6 months. It depends on the case. I would say some I've seen that they do it annually. And then 3 and 4 is the extreme case when they have a mural nodule that is enhancing. And then from management-wise, 3 and 4, they're not that different. For both of them, you should do urology consultation. And the urology, based on how, it depends a little bit. Depends on how suspicious they are and how old is the patient, how big is the mass, they decide to resect it or they do just surveillance. So don't get surprised if you see a weird mass that it has some areas concerning for thick septation and enhancement, but the patient is 80-year-old and they're still just doing surveillance because they didn't want to do surgery. So hopefully it kind of introduction to the cystic masses, but in real life you have some overlap. So for example, cystic nephroma, I'll show you a case, is one of those benign lesions, but if you look at the imaging finding, it could look weird. And in real life, if you have a patient, let's say if she is 50 and you have a multilocular cystic lesion, sometimes you cannot just say, oh, it's a cystic nephroma, we don't do nothing. Most of these cases, you put cystic RCC in your differential and eventually they get resected. There are kind of shortcomings with the Bosniak classification. One thing is that there is interreader variability. You will have a little bit of subjective difference when you look at the cases. The other thing is that many of the cases that we put in the category 3, if you remember, still they get urology consultation and they may go for resection. They're not necessarily malignant, but because you're just following the rules, you have false positive cases. So this is a paper from 2019 that I was talking about, 2 major changes that they made. One thing that is really helpful is they decided to define all the Bosniak criteria. To have so many vague terms when you look at the first Bosniak classification, or I would say the first versions. For example, they talk about the septae, or what is thin, what is thick, what is the enhancement. And the other thing that they added in the version 2019, they applied the terms to MR. So that was also helpful. I don't go through all these details. If you go to this paper and many papers that came out after this for validation, you could find this table. But I think it's helpful to put it in front of you when you look at a case. I personally don't necessarily memorize this, so some part you remember, but there are many details, but it's helpful to know where to find it. It's helpful to know there is such a table. It's hard to apply some of these on CT, but many of the cases that you get, they have multi-phase CT, and in some cases, especially if the patient is young, urologist may do an MR. So it's important to be familiar with the terms and how they are defined. And again, this is most of the management. Okay, benign simple cysts, for example, require no follow-up. These are the Bosniaks 3 and 4 that we were talking about that both consider urology consultation. So thinking about the cyst. So far we were talking about, okay, what is simple cyst? What is not a simple cyst? How we think about it. Sometimes you look at a cyst, and most of the cysts that we deal with, there are cysts that are a little bit larger. Here, I wanted to show you the cysts that I kind of call microcysts. They're a few millimeters, I would say less than 5 millimeters. In this category, I put a couple of differential diagnoses for each category. So most of the cysts that we see are the macro cysts or a larger cyst. And as you see, I try to put different attenuation on them. So for example, simple cysts, there are a few septations. So however you count it, it's 1 septation, 2, 3, or I don't know. This is kind of a Mercedes-Benz sign that people don't have consensus. Should we have 1 and 2 or 2 or 3? But none of these are thick. And here I wanted to show you that this cyst has a thick wall. There are different attenuations. Some of them are hemorrhagic. If you have a non-com CT, you put a RI and then you get attenuation 70 or greater than 70, you could call that hemorrhagic proteinaceous cyst. But if you get something like 40, 50 on the non-com and you don't have any contrast enhanced CT to see if that lesion is enhancing or not, it's a problem. So something to remember is that the hemorrhagic proteinaceous cysts, they have overlapping features with papillary RCC. Most of the RCC that we talk about are clear cell RCC. Most of them are very solid. But papillary RCC is a weird one because it's hypo-enhancing. It is not as avidly as enhancing as the clear cell. This is the reason we are a little bit careful when we find in a suspicious renal mass that we don't know what it is. So a few words about autosomal recessive polycystic kidneys. So why they look like this? They look this. Tons of echogenic foci when you look at under ultrasound. Basically, this is I wanted to show you. So this is a normal collecting system, and this is a patient with autosomal recessive kidney disease. So they have collecting duct dilation. As you see, it's very ectatic in this case, and as opposed to the normal one. This is the reason there are numerous reflection sites or surfaces when you have your ultrasound beam. This is the reason they look very echogenic. Something to know about it, many of these patients, they have intrahepatic biliary dilation. The worse the kidney findings, probably they have less hepatic disease. I told you I show you a case of multilocular cystic renal disease. This is a cystic nephroma. This is a disease that has bimodal age and sex distribution, so mostly in the younger boys and in the women of 40, 60 years old. I think in one of the review books, they're talking with Michael Jackson tumor. So again, going back, how does it look like? It looks very cystic, but this is a case that I was saying, if I see this case, it's hard just to say, oh, it's a cystic nephroma, it's usually benign, we don't do nothing about it. These are usually getting resected, and then we have the histology pathology. One feature that they're talking about is extension to the renal sinus. So in real life, it's not easy to find such a case, but on board, usually if they do something like this, usually they give you the right demographic, and probably you could guess what it is. So I wanted to show you microcysts. As I said, you could find it in patients who are chronically taking lithium. As you see, there are a ton of microcysts. This is a T2 image, and this is an ultrasound. As you see, they're echogenic. So polycystic kidney disease, again, you're familiar that they could have a lot of cysts in the liver too, and then they're associated with the cardiac valve disorders, and they could have brain aneurysm. It's a little bit less common lesion or pathology, I would say. If you look at the kidneys, these perinephric areas, just remember I was talking about the Ethheim-Chester disease. The difference is that if you remember that case, it was very soft tissue. And I told you, for example, for that case, I put a differential diagnosis of lymphoma. But if you look at this case, I'm trying to show you T2 here. So as you see, they are very cystic, and I could show you these are very thin septations. And as you see here, this is, if you put your RI here, probably you get something fluidy, less than 10 Hounsfield unit. And here I was trying to show you on the post contrast, it doesn't enhance. It's not something very common, but it's the case of lymphangioma or lymphangiectasia. So here you could kind of figure it out, probably their fluidy stuff, and here they could have also very prominent renal sinuses. So again, look at the features. Even if you haven't seen the pathology, you could describe it, and then you could look it up and probably come up with the diagnosis. So I don't know, I don't think that I have time to go over solid masses, but solid mass is something that Antonio will cover in that lecture. So let me show just one case, because that's a very bizarre case. So this is a case that I have from my residency. I can't remember the exact age, but he was maybe 50 or something. He was pretty healthy. He got the renal transplant, as you see here. So I'm at the level of the left iliac fossa. And then a few months after transplant, you see still he has scarring, so a little bit fluid around the kidney. Let's see if it plays. So I'm trying to show these multiple. Sorry if it was playing a little bit fast, but what I'm trying to show you is that, so multiple lesions in the kidneys, and then as you scroll, there are several lesions in the liver. His liver didn't have anything before transplant. And then in the visualized lung, I wanted to show you there are scattered pulmonary nodule. So it was a very unfortunate case that the donor had melanoma in remission, and I don't know for whatever reason in the screening or however they did, it was very remote, they didn't catch it. So unfortunately, the recipient got full-blown melanoma very early after the transplant. But it's a very extreme case. With that, so we talked about the anatomy of the kidneys. We reviewed some infectious inflammatory conditions. We reviewed some calcific disease, some miscellaneous disease, and cystic masses. With that, probably we are done. I don't want to take Carolyn's time. Let's see. I'm looking at the chat box to see if I talked about everything. I'll talk a few words about oncocytoma because Blaine, for daily practice, yes. For boards, they don't ask anything specific about 2019 update. But I think it's nice to look at the definition because it really clears the Bosniak classification. To me, the previous versions were really vague, but they don't ask any specific question. They don't show you a case to measure the septations or count the septations. Oncocytoma has very overlapping features with clear cell RCC. Most of the cases, we are not able to diagnose before we send the patient for surgery. So I wanted to case. So one thing that they talk about is that they have a central scar, central stellate scar. Not all the cases have it. This is an MR. Many cases really look like RCC. So and they're enhancing. Most of them, they're avid enhancing. So it's a diagnosis that it's difficult to be made before surgery, and we just know it after pathology. To know second most common benign renal neoplasm after AML, there's some association with TS, PhD, and again, there is no treatment. They will be resected because we always think they're RCC. Any other questions? I stop sharing. Okay, anything else? So hopefully I talked about most of the lesions in the chat box. I think I did. I will work with Bill and Marcus to see if Antonio could do his session. So. Okay, let's see if, yeah, Dr. Wang is here, so I don't want to take her time. Thanks, everyone. Have a great day and happy holidays.
Thank you.
Sure.
Thank you.
Hello, everybody. Looks like I don't see the poll functionality down at the bottom, which is really sad. Marcus, is that like something that has to be enabled on this Zoom thing?
I need to make you the host, and then you should have
Oh.
availability.
Okay.
See if it works for you now.
Yes, I see it now. Thank you.
Yep.
Okay. Let me just. Screen share. Okay. Hello, everybody. I'm Carolyn, one of the other abdominal imaging attendings, and today we're going to be talking about adrenal cases. It's going to be presented in a case format with multiple choice poll options, so please do try to participate. Okay, so the learning objectives: what do you do when you see an adrenal nodule? What recommendations to make for incidental adrenal nodules? Let's review some of the common adrenal masses and their mimickers and their imaging findings, and then finally the algorithm for assessing adrenal nodules. So as we know, adrenal glands are these paired retroperitoneal organs. They're suprarenal. They're usually inverted Ys, but they can be variably shaped, and they are made of two types of cells, cortex and medulla. And within the cortex, which is derived from the mesoderm, it secretes the hormones cortisol, aldosterone, and androgen, versus the medulla, which is derived from the neural crest cells and secretes epinephrine, norepinephrine. And the hormones are important because that's how people present clinically. So we'll start with this first case with a non-enhanced CT scan. Everybody can take a moment to look. And here's the question. And we'll go ahead and, sorry. Okay. Looks like we have about 6 answers, a few trickling in still, but we'll just go with that. Let's end the poll and show the results. So looks like a almost even split with slight edge for an adrenal washout CT and versus getting a history at 44%. And during that. And so the Hounslow unit was 36 Hounslow units. So the correct answer, get a history, since I've told you nothing about this person so far. And why is history important? Let's take a guess. Let's launch the poll. Okay, looks like we'll end that there with the majority, 88%, going with D to see if there's known cancer and a minority thinking the age of the patient might help, which it might, probably for the part number D too. And that is correct, known cancer. And here's the history on this patient, 51-year-old male with colon cancer and known liver metastasis. So why does it matter if the patient has cancer? We know that the prevalence of malignancy without a history of cancer in an adrenal nodule is less than 0.5%. We've had several studies, including Song et al., who found 0 malignancies out of over 1,000 adrenal masses in patients without a history of cancer. And most recently this year published out of China, where they do these unselected screening patients apparently and screen for adrenal nodules with CT. They found 0 malignancies out of over 25,000 patients. So, but if you do have a cancer history and you do have an adrenal nodule, then your chance of that being some kind of malignancy, either primary adrenal or metastasis, is 25 to 36%. Okay, back to our case of the 36 Hounslow unit non-contrast CT. So now these no longer get history, and instead it's do nothing. What is the next step that you want to do? Okay, with 65 respondents in, we'll end the poll there. Now the majority of people want to get that adrenal washout CT, and then a small number want to get a PET CT given the history of cancer. So yes, adrenal washout CT. So we know that adrenal nodules that measure greater than 20 Hounslow units on non-contrast CT, that adrenal washout CT is better at characterization than MR chemical shift, which almost nobody picked, and that's because of the difference in sensitivity. So with the non-washout CT, you have a sensitivity of about 100%, and then only 64% with an MR chemical shift study. So finally, though, to the important thing, what do you think it is? Okay, with 62 respondents in, the majority of the people suspected metastasis, and they followed by adenoma. I gave you this image 1 month prior. This is what the patient looked like, and also the additional history of that they just underwent a partial hepatectomy. Maybe also this image. So you see it was 36 Hounslow units on the pre-contrast, and it is 45 Hounslow units on the post-contrast. This is actually an adrenal hemorrhage. So The history certainly would have helped you out a lot had you gotten the full history. And on non-contrast CT, hemorrhage, can be hyperdense, particularly in more of the acute phase. And the patient had just recently undergone a partial hepatectomy of partially of the right lobe. You can see some edema there, and it was so in the case of adrenal hemorrhage, the values will be between 40 to 60 Hounsfield units on a non-contrast CT. Usually, you're given some sort of history, such as trauma, or they've got some sort of bleeding disorder, undergone maybe some sort of stress. They've multi-blooded burn, they're in the ICU, something like that, or they've had recent surgery. Typically, you're looking for some other signs to help you make this diagnosis, maybe some periadrenal infiltration or haziness, and then, of course, temporal change helps a lot. So this is about a month later. You can see that without any interval chemotherapeutic change, that the nodule got smaller and is now a little bit more hypodense. And then as these hemorrhages evolve over time, they can have calcifications or develop pseudocysts. All right, here is the next case. This is a contrast-enhanced CT scan, and the right adrenal nodule measures 46 Hounsfield units. Is there a size cutoff for going to surgery without getting a biopsy for an incidental adrenal nodule? Okay, ended there. Share the results. So the majority of the people thought nope, no cutoff, followed by 6 centimeters, and then the other choices. Right. So there is a size cutoff, and it's 4 centimeters. And so how did they come to this conclusion? So they looked at the prevalence of incidental adrenal cortical carcinoma in an incidental adrenal nodule. So you have no known cancer history, so you just have an incidentally found adrenal nodule. And what they found is that without that cancer history, if a nodule is less than 4 centimeters, the chance of it being adrenal cortical carcinoma is less than 0.5%, and it goes up to 5% if it's between 4 to 6 centimeters, and up to 35% for over 6 centimeters. And that there's also an increased risk if on the non-contrast CT, the Hounsfield units is over 20, if the patient is under the age of 18. And using this 4 centimeter cutoff, there have been surgical literature that uses that cutoff. It has a sensitivity of 93% for malignancy, although a rather low specificity. So if you up the centimeters, you would increase your specificity, but probably decrease your sensitivity. So 48%. Anyway, this person, now I've given you the history because history is important. This person's a 48-year-old female with abdominal and pelvic pain and then right adnexal mass. We actually went on to an MR scan. Here's an axial T2 of that right adrenal nodule, which is iso-intense to the liver parenchyma. And then on an in and out of phase, but hopefully, is the diagnosis. Okay, I know not all of you have had MR, so, but the majority of you do believe it is an adenoma, which is the correct answer. And a follow-up question, what malignancy listed on this list is not known to also potentially cause a signal loss and chemical shift?
Is not known.
we'll end the poll there. And small majority thought colon. Other choices included the renal cell and pheochromocytoma. So what do we see? We see signal dropout between the in and out of phase, which implies that there's cytoplasmic fat within this lesion, and it is not known to happen with colon cancer. But it does happen in renal cell and HCC because they can have fat, and also very rarely so can pheochromocytomas. So you see that signal loss on a post-phase imaging. There are actual percent thresholds, but most people just eyeball it. And it is more sensitive than just merely a unenhanced CT for this appearance of intracytoplasmic fat, particularly when the Hounsfield units are in the lower range, as we had discussed before, but the sensitivity drops off once you get into the higher non-contrast Hounsfield. And that's why we prefer the washout CT. So again, things that can have false positive can have intracytoplasmic fat, such as HCC, clear cell RCC, and PHEOs. If they do, it's usually a very small part of the lesion that's undergone some fatty degeneration. It won't be the whole nodule. And then other more rare etiologies, including adrenal lymphangiomas, and then even adrenal cortical carcinomas can also and drop out. So this was an adrenal adenoma, which is found in about 1% of the population, seen incidentally about 5% of abdominal CTs, can also be seen in cancer patients, which is why it's so difficult to distinguish and a kind of a diagnostic conundrum. And if you have a history of cancer, you have a 43% prevalence of having any kind of malignancy in your adrenal nodule during your cancer staging. These adrenal adenomas are associated with some syndromes such as MEN1 and Carney complex. The older you are, the increased incidence you have, up to 6% of the time. And then there's other ways to diagnose the fat, and one technique is called CT histogram, and that's where you're doing pixel by pixel evaluation of your Hounsfield units and trying to find greater than or equal to 10% negative pixels within your region of interest, which in the literature has been reported to have a fairly high sensitivity and specificity, although some argue this depends on your noise and your scan technique. So because we now do more low-dose scanning, as a result, we end up with more noise in our scans, and the noise causes more falsely negative pixel values. And so you need to correct for that noise. So for example, on a PET CT, that CT scan, you could draw a region of interest around it, but depending on how noisy it is, you may have to correct for the noise. And so one of our ex-fellows did a study in which he looked at adrenal nodule region of interest and found that they follow a Gaussian distribution, or essentially a bell curve, and that if you know the information such as your mean attenuation, your standard dev, your slice thickness, your MAs, and your pitch, that you can then mathematically correct for that noise. And so if you're wondering and you feel like, oh no, I think this scan may be a little too noisy, you can try to correct the noise and see if you can get a less than 10 Hounsfield units on your attenuation correction CT for your PET and kind of nail that diagnosis. So what about some other techniques that we do have within our system? We do have dual energy CTs. We have dual source, which we're obtaining data from 2 X-ray spectra and try to improve tissue differentiation. So we can generate virtual unenhanced from our GE scanners. And what we've seen in the literature is that with that, then can we characterize these adrenal nodules so the patient doesn't have to come back and get another scan and another dose? And it works pretty well, especially if the nodule is over a centimeter. Here are the sensitivity, specificity, and accuracies in the high 90s, but it suffers, again, in the less than 1 centimeter, probably, again, related to like noise distribution problems and small size, and you're in the retroperitoneum. And when they did side-by-side comparisons of these virtual unenhanced scans compared to the true unenhanced scan as the gold standard, there was good agreement, but there was a trend towards overestimation on the virtual unenhanced across all the platforms. And so if you get less than 10, you can be pretty confident it's an adenoma, but if you're over 10, it doesn't mean it's not an adenoma, essentially. And it's kind of a plus minus 10, so like it could be 20. It's a valid, you can draw just an ROI on your VUE in the PACS if you're looking at one of the GE scans, but you cannot do that for Siemens because that's not a valid Hounsfield units, and instead you would have to go to their post-processing platform, which is Syngo, to do it. So in general, though, you see an incidental adrenal nodule. Can we just ignore it? I mean, we see them so frequently, obviously. And the answer, unfortunately, is not quite. Clinicians are going to still want to work it up, at least hormone-wise, if it's over a centimeter, because a small number of them will be benign, functional, adenomas or pheochromocytomas. Even in patients with no malignancy, they can just be adenomas or pheos. So most recently, this year, the American Association of Endocrine Surgeons put out some guidelines for adrenalectomy, and so they did some imaging surveillance recommendations. So they said for non-functioning, so they've already done the biochemical evaluation, and it's negative, the adrenal nodule that measures less than 10 Hounsfield units on a non-contrast CT and measures less than 4 centimeters, so that surgical cutoff, then no further surveillance, no other imaging, nothing else has to be done. But the nodules that are between 1 to 4 centimeters that are measuring higher than 10 Hounsfield units on a non-contrast CT should have at least one repeat imaging and they give a rather large range, 6 to 12 months, to confirm stability. And then if it's stable, then you don't have to do any other imaging follow-up, but you could do another hormonal evaluation either between 2 to 5 years later. So what about if these nodules are greater than that 2 centimeter and grow? So they said if it's greater than 2 centimeters, grows more than 1 centimeter within 12 months, then you could go to resect it. But if it's smaller, so if it's in like kind of 1 to 2 centimeter range, or the growth is smaller than that, you could also consider repeat imaging at another 6 to 12 months, but there's no good data on when to do this surveillance and for growth. So, and then they recommend that you do not resect something that pathognomically looks like a myelolipoma or an adrenal cyst unless it's causing some sort of mass effect, so you've got some symptoms related to it, or it's substantially grown or bled. So what do we say about adrenal nodules in the radiology world? So the last thing that came out on incidental adrenal masses was a white paper in 2017. And the upgrade from 2010 to 2017 is that they did recommend more evaluation of these masses between 2 to 4 centimeters without a history of cancer, given the increased risk of malignancy. They also included more PET CT and biopsy as options for oncology patients. They added information that you could use dual energy CT to help characterize, and you could even use perhaps reduced dose radiation CT. And then they said the biochemical evaluation could be considered, although there's not a lot of research on this. So obviously the endocrinologists want us to do it, but radiology doesn't. So here's the flow chart. And so we are in this category of no prior imaging, but we do have a cancer history, so we should go to an adrenal CT, washout CT, and then follow that algorithm. Okay, so in the paper, they also mentioned things like maybe suspicious morphologic features. So the question from the 2010 paper was, what exactly does morphologic suspicious features mean? And so Song et al. Also looked at this and said, okay, let's look at 211 adrenal masses on their initial contrast-enhanced CT and see if we can figure out if they're benign or malignant just by these imaging features. And what they found was that no imaging feature was reliable at predicting benignity. Such things as smooth margins or homogeneous density, while commonly seen in benign lesions, lacked specificity because 32% of malignant masses also had that appearance, particularly small ones. So then they flipped on the other side and said, what about, are there any features that have associated with increased risk of malignancy? And they did see that if you had a thickened enhancing rim with a central low attenuation, so presumably enhancing mass with central necrosis, that was associated with the malignancy with a specificity of 98 to 99%. But the problem was it was only seen 5% of the time. And then also irregular margins seemed like a feature that might work. The problem mainly becomes, though, that they left 13 to 15% of their nodules classified as indeterminate, so they didn't know if it was benign or malignant. And within this group, the rate of malignancy, depending on the reader, was somewhere between 21 to 50%. So for one person, it's just a flip of a coin. But you would still need to have to follow those because you're not really sure if it's suspicious or truly suspicious or not. And then that moderate inter-observer agreement, which is not good because that means that you and I might not agree anyway to begin with. However, it does seem that if you do see an adrenal mass that has irregular margins or thickened enhancing rim with central necrosis, that they're more likely going to be malignant. So take-home points, incidental adrenal nodules over 4 centimeters, consider resection unless they're imaging benign and asymptomatic. The surgeons recommend actually sending these patients to a multi-D conference to kind of decide on management. And without a history of cancer, incidental adrenal nodules are likely benign. Next case, 82-year-old male with a history of intermittent diarrhea and constipation with weight loss and an incidentally detected adrenal mass. Going to be an adrenal mass on the left side. I'm going to leave these 3 images for you to review: 2 axial post-contrast and a coronal. Then I'm going to ask you what you think it is. Poll. Okay, we'll end that there, and the poll. Good. So the majority of people, 55%, thought it was an adrenal cortical carcinoma. So I will say, congratulations. There was a St. Elsewhere physician radiologist who did not make this diagnosis, but you guys did make this diagnosis. So, and this is the PET CT because they were worried about a metastasis. They wanted to work it up, so they looked for a primary mass. They got this PET CT. And the clincher for this, which you could have made on the contrast enhanced CT, was the fact that there was this, the tumor was extending into some sort of vascular structure, which on the coronal turns out to be the adrenal vein. And it's expansile. It's bigger than any adrenal vein anybody's ever seen. And there's kind of this mixing, which is hard, right? Because maybe it's unopathified blood, who knows, mixing. But the blood coming from this kidney is pretty opacified, so it's sort of weird. I mean, you can understand this mixing over here, but this seems a little weird. And it does show up to be all FDG avid tumor in vein. And we know that adrenal cortical carcinomas like to go into the vein. Adrenal cortical carcinomas are rare, accounting for only 0.05 to 0.2% of all malignancies and 1 out of 1,500 adrenal tumors. At presentation, 20% of them will have metastases. They are associated with some syndromes, such as Beckwith-Wiedemann, Lee-Fermini, and MEN1. If they're less than 5 centimeters, they're usually found because they're functional, so they have secretions of hormones. Depending on what hormones are being secreted, they are whatever symptoms. And then if they're not found until they're over 5 centimeters, that means they probably are non-functional, so you didn't have a reason to go looking at any adrenal glands, which is about 54% of the time. And instead, they present with some sort of vague abdominal pain or mass, or it's incidentally detected. And if they present with metastases, they like to go to the liver, the lungs, and the bones. And it's a bimodal distribution in young kids, less than 5, and then kind of middle-aged people, and more common in female than men. Staging, so size, less than or greater than 5 centimeters, and then they like to know about any kind of local invasion. But you'll see that in almost every choice, they try to go to surgery because unfortunately this is a very aggressive tumor and there's not a whole lot you can do. So they are going to go to surgery even if you're locally invading into the fat, even if you're involving adjacent organs such as the kidney. They are depending on what they can take out, and even if there's nodal disease, they go to surgery, but they know it's not curative. But remember, it likes to do tumor in vein or tumor thrombus, so look in the renal vein, look in the IVC. This is important, especially to look for the cranial extent of the potential tumor thrombus to see if it goes super diaphragmatically and if they need like a cardiothoracic surgeon also to be there, or somebody else to deal with the tumor that's above the diaphragm. So survival is not great. It's 18 months, although it's better for kids. And again, it's more commonly seen in the left adrenal. So in CT, it's going to be a large suprarenal mass. Frequently, it's going to be aggressive with invasive borders, and that might give you a tip-off. And they tend to be unilateral, though 10% can be bilateral. If they're big and they grow fast, they can get necrosis, they can have hemorrhage, calcifications in about 30% of them, and they can even have the FAP, which is why they can have signal dropout in MR. So they're usually going to be low in T1 compared to the liver, high compared to the liver on T2, and heterogeneously enhanced, and they're usually FDG avid. So take home point, think about an adrenal cortical carcinoma when you see a large suprarenal mass with aggressive borders. And usually they're going to just go straight to resection if you're suspicious that's an adrenal cortical carcinoma rather than biopsy, because you can get these false negatives where all you get is adenomatous tissue, and you can also cause tumor seeding. Remember to look for vascular invasion. All right, here's another case. This is a 3-phase adrenal study. This is a non-contrast. It's a right adrenal nodule at 32 Hounslow units, and this is kind of your portal venous 99 Hounslow units, and then your 15-minute delay at 56 Hounslow units. Hold on. Tell you the answer of the relative and absolute washout, 43% and 64%. And now I'm going to pull you to ask what you. Okay, we're over the 50%, so I'll end the poll there. So the majority of people think it's going to be a lipid poor adenoma, followed by an even split between a metastasis or adrenal cortical carcinoma. Here. So just before I reveal anything, let's just go back in case you didn't know the equations that were calculated for you. Absolute washout is when you have an unenhanced CT, and relative is when you do not have an unenhanced. So absolute, you're going to be enhanced minus delayed over enhanced minus unenhanced, whereas relative, you're enhanced minus delayed over enhanced. And then the cutoff for a 15-minute delay is going to be greater than or equal to 60% should be a lipid poor adenoma, and greater than or equal to 40% relative. And the sensitivities and specificities. However, there is a little bit room for error, and the reason for that, and if you don't know the equation, you don't have to memorize it. You can Google adrenal washout calculator and have one for you where you just put in the values and it lets you know what it thinks it's going to be. In this case, this patient, again, history is your best friend, 65-year-old male who was post-right nephrectomy for renal cell carcinoma. And now with that history, perhaps you want to consider or not. And then also the fact that I'm giving you a 6 months prior study. Okay. Majority now have decided it's probably a metastasis, which is correct. All right, so there are false adrenal adenoma washouts, and particularly hypervascular metastases can wash out, such as HCC and RCC, and then pheochromocytomas, who are also known to be very vascular. And in the literature, there are even case reports of even hyperplasia causing false washout. So there are some studies that suggest that maybe this washout is not the end-all be-all of everything. Okay, so take home, adrenal adenomas. The reason they wash out more rapidly than metastases is because metastases have leaky capillaries, and so they allow the contrast to kind of leak out, and they don't wash out. But hypervascular mets do, and so you want to watch out if you see a history in the patient of having an RCC or an HCC, and looking at those prior studies are going to be your best. Next case, a 67-year-old female with a remote history of an enthesineoblastoma, like one of those kid tumors, 27 years ago with an incidental right adrenal mass seen on a spine MR for back pain. So I'm showing you the MR from this MR spine where we've got the post-contrast T1, and you can see this enhancing mass right there. And then this is the coronal T2, where it's intermediate density, but it's higher density than the liver. And here are some choices. Just waiting for it to hit 50. Almost there, 44%. Few more people. Go. All right, we'll end the poll. So the majority of people by a bit were thinking it's going to be a pheochromocytoma, and then followed by metastasis. And I will say that this was my case, and I thought that it was either going to be a metastasis or an adrenal cortical carcinoma, because remember, like those infiltrative like tumor, this is clearly invading into the liver, shouldn't be an adenoma because if it's invasive borders. I think pheo is not a bad choice either. And then they went and biopsied this, and this was a metastasis. Actually, I think they just resected it. So adrenal metastasis. About 50% of patients with adrenal masses and cancer, when they did autopsies way back in the olden days when they used to do those, they did find that they harbored metastatic disease. And their question? Sorry. Okay, so for metastases, the most common cancers that are metastases is going to be lung and breast, which are, of course, the two most common cancers, and then melanoma, because melanoma likes to go everywhere, and then thyroid, kidney, and GI tract. And then if it's lymphoma, it's usually secondary lymphoma. On imaging, it can have central necrosis, hemorrhage, calcification, and that enhancing rim. And in terms of like all sites of metastases for cancer, it's the fourth most common site behind lung, liver, and bone. They can present asymptomatically or with Addison's disease. And they did a study out of MD Anderson where they got a bunch of referrals for occult malignancies, and they only found 4 cancers that just presented in the adrenal glands. And so there was like no other source of cancer anywhere else except the adrenal glands. And in those, they were all over 6 centimeters, and 75% were bilateral, and they argued that these were not incidentalomas because these people had other findings that made them suspicious that they had some sort of cancer somewhere. So again, remember, small tumors can, unfortunately, look kind of homogeneous. They can even maintain the contour of the adrenal gland, but the larger they get, the more abnormal they get, and the more heterogeneous they get, and the more chances they have like necrosis and hemorrhage and all this other bad stuff. MR, they tend to be lower on T1 and higher in T2 unless they have hemorrhage, in which case depends on the age of the blood. And then for PET, you can just use the relative FDG avidity compared to the background liver. And there was a meta-analysis looking at how good FDG PET was for characterizing adrenal masses as either benign or malignant, and they found a 97% sensitivity and 91% specificity. And the things that they thought you had to be careful about were lesions that were less than 1 centimeter, although maybe now it's better because of the better detectors that we have. And then benign lesions can also have mild uptake, such as adenomas. And then they looked at whether you needed to actually quantify it, or could you just qualitatively look at it, and qualitative was just as good as actually quantifying it. So this is a 44-year-old male with a history of sinonasal melanoma. And you can see there's a right adrenal. This is the accompanying PET CT. And I'm going to give you some other images. So that was the original data set I showed you. And now this is 1 month after nivolumab, which is an immune checkpoint inhibitor therapy. And, oops, stop sharing. Oh, I'm sorry. Were you able to see any of that? I forgot to close off the poll.
Yeah, we were able to see it.
Oh, okay, excellent. Right, here is the new poll. Okay. More people to get us over the. There. So the majority of people thought it was a metastasis. And then the second group thought it could be a collision tumor. And those people are very astute. And perhaps what they noticed is that in your original scan, you saw that there was kind of this hypodense component to this mass and then this more soft tissue component. And oops, I thought I showed it, but okay, let's. And then if you look at where the FDG avidity is, it's like associated with that more soft tissue component. And if you look, that soft tissue, that part of it is what kind of resolved. But then that hypodense part kind of remained. So it is indeed a collision tumor. And a collision tumor is coexistence of histologically different tumors existing separately but in the same space and increasing. So some things that could make you make this diagnosis, which is very difficult and usually needs biopsy, so it's hard to make a priori, is that you see perhaps a previously characterized adenoma suddenly have a soft tissue component that it didn't used to have. On MR, maybe there's this focal area of dropout only on part of the mass and not the whole mass, and then if with the FDG, having a focal FDG uptake. So there are collision tumors and composite tumors, just to recognize them. But on imaging, I think we cannot tell composite tumors. This is more of a histologic diagnosis because in collision tumors, the cells independently coexist without significant tissue admixturing. But then in composite tumors, they're like admixtured right next to each other. So I think we can't really. So if you see an enlarging soft tissue component in a previously characterized benign lesion with a known history of malignancy or an enlarging adenoma, then you can raise a suspicion that there is a collision tumor. So let's talk about that PET CT, how valuable, again, we had talked about Boland and all, and let's look at some of the sources. So in this case, they just said, if I add PET CT to an adrenal protocol CT, how much better am I at characterizing these adrenal nodules? So they saw that adrenal CT already had an accuracy about 85%. PET CT alone, if you just subjectively did greater than the liver, it was 89.7%, and then combined, you barely went up, but you did a little bit to 91.2%, and the sensitivity went. So when is it wrong? So you get these false negatives 3 to 13% of the time, especially if the nodule is very necrotic, so you don't have enough viable tumor to have FDG uptake. If it's very small, less than 1 centimeter, and then things that can cause false positives. Again, adenomas, about 5% of them 5% of the time they can have FDG avidity. Usually they're going to be the hormone secreting ones, and then these other diagnoses as well, including hyperplasia. So cancer history, again, is going to really help you make these diagnoses. Remember that qualitative PET, you're looking for an SUV greater than liver. That's going to make you suspicious that that's something bad. Watch out for nodules that are less than 1 centimeter, though, or if they're known to have low FDG avidity primaries, like mucinous neoplasms, for example, would be something that typically doesn't have FDG. So then if the primary doesn't, then the MET won't either. And then remember that that non-contrast attenuation correction CT can be used to help you make the diagnosis if you're wavering, if somehow the FDG is not helping you out, or you need a little extra boost for your confidence. Next case is a 63-year-old male who's post-heart transplant with melena. Got a right adrenal nodule, which is on this non-contrast CT kind of heterogeneous. So already at baseline, you wouldn't trust your ROI if you got less than 10 because you're not supposed to do it on a nodule that's heterogeneous like this because it could be, this could be a necrotic lesion, which actually after the post-contrast, it does appear to be that way. But then on T2, it's also right here. So it's T2 hyperintense compared to the background liver. Thoughts? Okay, we'll end the poll there. And the majority of the people thought it was going to be a pheochromocytoma, and that is correct. Perhaps it's because of that very bright T2 appearance to this right adrenal gland that helped them cinch that diagnosis, although not quite as bright as the fluid in the stomach, quite a bit brighter than the liver. And that is a feature that can be seen with pheochromocytomas, and pheochromocytomas are tumors from the chromaffin cells of the adrenal medulla, and remember they arise from those neural crest cells, and because of the epinephrine and norepinephrine, their symptoms are going to be proximal headache, hypertension, palpitation, sweating, arrhythmias, pain. They're usually seen in relatively younger patients, 20 to 30 years old, and you can check elevated VMA levels in their urine. And they're considered malignant if they have metastases, which is 2 to 4% of them at presentation. And you remember, before you want to biopsy them or resect them, you want to treat them with the alpha-beta blocker so that you don't induce a crisis. And they are associated with several syndromes like VHL, MEN2, NF1, tuberous sclerosis, and Sturge-Weber. There classically was taught this rule of tens, which has been recently rebutted. Many of them still more or less stay, but the one that was the most changed is probably the 10% were thought to be familial, but now that they do all these germline testing of all these tumors, they found that actually germline mutation accounts for about 25% of these pheochromocytomas. So 10% of them are extraadrenal. They're going to be along the sympathetic ganglion chain. 10% are going to be bilateral only if they're sporadic, not if they're associated with a familial thing. 10% of them are going to be malignant with distant metastases, and 10% of them will be extra-abdominal, 10% of them found in kids, and 10% of them will not have any associated hypertension symptoms. On CT, they're very variable in appearance, so that sometimes they're called like the mimicker in the adrenal gland. They can look like almost anything, so you can always throw out pheo as a possibility. Sometimes they can be well-defined and homogeneous. Sometimes they can be very complex with calcifications. They can be cystic, necrotic, enhancing. However, if you do see on post-contrast like an avidly enhancing lesion, besides your hypervascular mets, assuming the patient doesn't have a known history of any of those things, then there has been some data suggesting that if the Hounsfield units are over 110, 120 on your post-contrast study, then it's probably, you can raise that pheo as like higher on your differential, and that they should then correlate with serum catecholamines. And the T2 light bulb bright is because of the cystic necrosis appearance, which is highly specific but lowly sensitive for distinguishing pheos. And in this study from Corwin in 2021, where he looked at other stuff, including evaluating washout, this is why he wrote a piece saying like washout is dead, we should not use it anymore. And basically because in his study, 5 of 9 of his pheos did have that washout that we talked about because it can be a mimicker. And then, but also as well, 10 of 20 adenomas, only 10 of 20 adenomas did as well. So he just, and all of these nodules were path proven. So, and then again, that increased T2 signal, that light bulb bright necrosis, unfortunately happens less than a third of the time. So most of the time you're not going to see it. And it can be uptake on I-131 MIBG. And it's useful, these neuroendocrine or the nuclear medicine studies, when you're looking for ectopic or recurrence or metastases. And then even though we had said that you could sometimes get signal dropout with fat, right? It's so rare to see that it is almost case reportable. So you would put it at really low on your differential. And maybe not even, unless you had other features that were suspicious. These are just some examples in the literature showing some nice extra adrenal pheochromocytomas that have that light bulb bright appearance. Okay, and then this is the next case, a 70-year-old male who had abdominal pain and was found to have an incidental left adrenal nodule. Here again. We're almost at 50. Okay. So the majority of people thought this was going to be an adrenal myelolipoma followed by a liposarcoma. I think that A is a very reasonable diagnosis. I think this is what was originally proposed. But the actual diagnosis is a liposarcoma. And liposarcoma, so basically you see a fat and soft tissue density mass. It seems to have a capsule, which is why probably the myelolipoma seemed benign. It didn't seem very infiltrative in its appearance, as you might hope to see for a liposarcoma. So for liposarcomas, they're rare. They're going to be usually retroperitoneal in origin. Sometimes it can be difficult to assess exactly where it is when it's very large. This is where I usually recommend that you put a cursor in the center of the mass to help you kind of distinguish what organ it could be coming from or what area it's coming from. And it's going to have mixed fat and soft tissue density. It can rarely undergo cystic degeneration, so it can even simulate a benign cystic lesion. So the differential diagnosis would include a renal AML as well, if it was arising from the kidney, because we know those have hematomatous tumors, so you can have blood, muscle, fat. And if it were a renal AML, then 20% of the time they're associated with tuberous sclerosis. 80% of tuberous sclerosis patients have AML. You're looking, if you think you can find that renal defect, for that claw sign, and then also a prominent draining vein. And the retroperitoneal liposarcomas, in contrast, rather than coming from the kidney, would be compressing the kidney and can extend beyond that perirenal space, and you don't see a lot of vessels usually. More benign differentials that you might have thrown in could also include retroperitoneal hemorrhage, usually a little more infiltrative appearing because of the blood bleeding out, and then there's hopefully a history, something related to trauma. This is a companion case of a 38-year-old female with just incidentally, working up a ventral hernia. Again, in the left suprarenal space, we see a fat density mass. This one has actually a prominent vein and a soft tissue nodule. Even though it has that vein, it doesn't appear to be arising from the kidney. It has a pretty good fat plane just pushing on that kidney. So we're at a tie between an adrenal myelolipoma and a liposarcoma. And I guess I gave you too much information, so you excluded the renal AML. And in this case, you had a comparison from 5 years ago where it looked the same, so that allowed to reassure you that this is going to be benign. So these are, again, rare benign tumors and that have fat and hematopoietic elements. They tend to be quite large, 2 to 10 centimeters in the suprarenal location. They are found incidentally and usually unilateral, but they can bleed and necrose if they are large. They're usually non-functional, most commonly seen in the elderly. You're looking for that fat attenuation, between minus 30 to minus 90 Hounsfield units. You hope for it to be encapsulated. Although 20% of the time they can have calcifications, so they'll usually punctate calcifications. And even though they're usually asymptomatic, rarely they can have endocrine dysfunction. So just some cases in the literature, this is a case of a renal AML where you're seeing that defect in the claw sign in the kidney and then that prominent vein. And in this case, it's another liposarcoma, which is just pushing, and you can see that it extends beyond what you expect with the perirenal. So again, take-home points, put the cursor in the center of the mass to figure out where it's coming from. See if you can tell if there's a claw sign to show an origin or a mass effect. Look for some separate normal structures, and then they're going to always check endocrine values to see if there's any. So in conclusion, we've talked about a bunch of adrenal masses, but luckily without a history of malignancy, these are most likely going to be benign. things that can help you nail that diagnosis. If you've got less than or equal to 10 Hounsfield units on non-contrast CT, or if you see signal dropout in and out of phase MR, you've got a FDG less than liver background on your PET CT. Also look back for comparison studies, because Mets don't sit around doing nothing for years and years, nor do bad things like adrenal cortical carcinoma sit around doing nothing for years and years. And if it's a CT that was done with dual energy, as so many of ours are, then you can use that virtual non-contrast and try to see if you can get less than 10 Hounsfield units and also nail it and not have to come back and look at it again. But remember, if you do see suspicious features, heterogeneous necrosis, irregular margins, then it's probably going to be a metastasis. So you could either go straight to biopsy or resection without having to stop at an adrenal nodule CT, because like having these suspicious features means that you're not going to be an adenoma, which is basically the whole point of the washout CTs. You're hoping to make it an adenoma. When you know it's not, then don't bother recommending that scan. Extra study and more work for no gain. Okay, so bottom line management, you've got an incidental adrenal nodule less than a centimeter without a history of cancer. You don't even have to do anything about that imaging-wise, but they may choose to do some sort of biochemical assessment. And if it's between 1 to 4 centimeters and greater than 10 Hounsfield units, and it's not a myelolipoma or a cyst, they're going to first start with biochemical evaluation and then just get one follow-up exam as a non-contrast CT at the 6 to 12 months, just to see if it's growing significantly or just being stable. If it's stable, then they're going to let it go. If it's over 4 centimeters, they're just going to go straight to resection unless there's something about the imaging that makes it a definitely benign and asymptomatic lesion. And part of that biochemical evaluation is important because they want to make sure it's not a PHEO, so that they could pre-treat before they do any biopsy or surgery. All right, thank you for your attention. Any questions? Okay,
Thanks, Carolyn.
my pleasure. Thanks,
Thank you.
everybody. Have a good evening.
Thank you so much.
Thank you.
Thank you.